two categories of classification. We have primary hypertension. We have also secondary hypertension. So you find that most of hypertensive cases are actually primary hypertension. These are cases that the cause is not very clear. Pathogenesis is not clear and may be associated with we have compounding effects of various factors that are combining to give us a patient with hypertension. So you're going to find factors like genetics, you're going to find environmental factors, all these working together to give us a patient with hypertension. So you find that we cannot put a finger on exactly what caused the hypertension, but we are presented with a patient with hypertension. So this is the vast majority of our patients living with hypertension. The other is just a small group, but of course still a significant number. That is about 10% of the cases having secondary hypertension or non-essential hypertension. This category normally has, something you can call a cause you can place a finger on, something you can blame and say this is the cause of the hypertension in this patient. So treatment could be directed particularly to eliminating the cause of hypertension when you're trying to handle secondary hypertension. So things like pheochromocytoma. We know that when a patient has hypertension secondary to this, there is a way we manage them. When patients have hypertension secondary to thyroiditis, there's a way we handle them because we know the cause. Okay, but when it comes to primary hypertension, we don't know the real cause, so the management is a bit different as well, as we shall see. So, in the diagnosis of hypertension, it's very important to know how to measure blood pressure. Okay, usually someone can easily make a wrong diagnosis of hypertension if they do not follow some of the criteria for measuring appropriate criteria of measuring blood pressure. Number one, usually when we are taking blood pressures in an office setting or in a clinic setting, we will like the patient to have a seat. Okay, they will have a seat, and this seat must have somewhere to support their back and somewhere to support their feet on a flat floor, and then also somewhere for them to place their arm on a free sort of table or plain surface where they can place their arm at the level of the heart. So the patient should number one should not be talking during or between measurements, okay, because we know that these will elevate blood pressures. Then the cuff to fit. We have seen scenarios where we are measuring someone's BP, pediatrics. We are measuring BPs of someone who is obese or someone with a very large biceps. We are using a cuff for a normal person with a normal circumference of the arm. So it's important to be aware of this. Also, we need to have the arm bare. The arm that you're going to use for measuring blood pressure should be bare and should be resting at the level of the heart, so that we can have a proper, measurement. So then the other thing is the machine we're using has to be validated, calibrated, depending on what you're using. If it's electronic, it has to be validated. And if it's our usual manometers, we can actually calibrate them. Then the room has to be quiet, because we know that sometimes unnecessary noises or, abrupt noises can actually, elevate someone's BP. The patient has to be comfortable in the room. The temperature has to be room temperature, or one that the patient is comfortable with. The patient shouldn't have smoked, Smoking, we know that smoking elevates BPs. So these are things you have to ask the patient first. Have you been smoking, or when did you last take coffee, or things like that? Or if they've been walking to come to the facility, then they should be able to just sit for about 3 to 5 minutes and rest, so that we can have a proper, blood pressure. And then the patient should have an empty bladder. We know when someone is pressed, chances are high that their BPs will go up. Then we take 3 measurements at 1 minute intervals. Usually we will prefer to use different arms. so that we have an average of the last two measurements. The first measurement tends to find the patient a bit anxious because they're seeing you and anticipating what will the outcome look like or things like that. So you want to take an average of the last two measurements. So we see that the process of taking the blood pressure of a patient is very important, so that we have an accurate reading, so that we don't misdiagnose a patient. We're going to go straight to how do we classify blood pressure. Initially, according to JNC7, JNC7, that was in 2003. We were looking at classification of hypertension or blood pressure. As you can see on the chart, uh, normal blood pressures were less than 120, less than 80. And then we were having a category called pre-hypertension. Pre-hypertension was that category between 120 all the way to 139 of systolic. Okay, and then we were having diastolic, from below 89. Below 89 would be our pre-hypertension. However, things changed a bit, and you can see the stage one was a little high, 140 to 159 systolic, and then 90 to 99 of diastolic. And then our stage two was starting from above, 160 onwards systolic, and then 100 onwards diastolic. But then in 2017, the American College of Cardiology or American Heart Association became more stringent with their classification of blood pressures. And then they eliminated the pre-hypertension group and then reintroduced a new term that we call elevated blood pressure, as you can see on the slide, that orange box. And that elevated blood pressure these are patients who have BPs that are 129, systolic, and with a minimum systolic of 120, and then BPs which are less diastolic of less than 80. And then stage one was brought closer, okay? Closer. So patients who are 130 to 139 systolic have been classified as stage one hypertensive. And then patients with 80 to 89 diastolic have been classified as well as patients who have and then stage two from one and then two. So where you're seeing the red boxes, they show you hypertension. Okay, so in 2003, hypertension was, where the red is. Now we are seeing that stage one has been brought closer. Okay, it has been brought closer. Is much bigger now, it's beginning from 130 going onwards. One thing we have to note that is very important is one of these categories of hypertension, and then the diastolic is normal. We will still diagnose them as hypertensive. And then if the systolic happens to be normal, but the diastolic is out of range, we will still diagnose them as what? Hypertensive. So it doesn't matter which one is out of range, which one is normal, or if both of them are out of range. Okay? So if any diastolic or systolic is out of range and falls within the criteria of what we will take, okay? Pressure or hypertension or isolate diastolic hypertension. So we have some treatment goals when we are treating patients who have hypertension. According to the European Society of Hypertension, 2023, patients who are 18 years of age up to 64 years of age, the goal of therapy for them is less than 130. Okay, less than 130 systolic, less than 80. Okay, and then for patients who are 65 years of age to 79, we tend to target less than 140 systolic and less than 80 diastolic. But we say that if they can tolerate our antihypertensives, we can even become more aggressive and target less than what? 130 systolic. Okay. So in other words, what you're trying to say is a low BP, as long as it is within normal or within normal for a patient. Okay, you shall notice with time that blood pressures are normal for some patients, and then for others they might be abnormal. So for so long as the BPs are normal within range, we always like to have it as low as possible. Okay. So a low BP is something that is good for a BP that is as low as possible is good for us. Okay, without us causing hypotension in a patient. That's what I'm trying to say. Okay, so the lower the BP, the better for us, as long as it is within our target ranges. So patients who are 65 to 79 years of age with isolated systolic hypertension, like I mentioned already before, the primary goal of treatment is to lower our systolic blood pressure to, to 140 to 150. Okay, that's a range we would like to bring it to. If the patient has an isolated systolic hypertension, where we are having systolic blood pressures out of range, but the diastolic is normal, we'll want to have the systolic between 140 to 150. However, a reduction of systolic blood pressure to a range of 130 to 139 may be considered okay if the patient can tolerate our antihypertensives, okay? And we have to make sure that we take caution if the patient has a diastolic blood pressure that is below 70. Okay, you don't want to crush their blood pressures. Remember that our diastolic blood pressure is in pond chambers or within the arteries when the heart has done what? Has relaxed. You don't want to drop those diastolic, them around 70. So in a patient who has that a diastolic is below 70, you don't want to be very aggressive. These patients should be lower to a range of 140 to 150 systolic. Then diastolic of 130 to 139, we would like to achieve those. And again, we are saying that if we are having a diastolic of less than 70, then we have to treat carefully because we might end up having a hypoperfusion in such a patient. We don't want to treat hypertension and then again end up sending the patient into shock. So let's look at what the American Heart Association says. The American College of Cardiology. These are guidelines that there was a scientific statement that were made by this group of professionals, and this is what they came up with or they settled with. So we have BP thresholds for treatment initiation and follow-up. So we are saying that in patients who have normal blood pressures, okay, less than 120, less than 80, we can promote optimal lifestyle habits. Okay, that is what we do. Basically, lifestyle habits. We encourage them to reduce salt, to maintain a low salt intake, to maintain a life where they're not smoking, to maintain a life where their lipid intake is low, to maintain a life where they're physically active. So we want to, when someone has a normal blood pressure, we want to encourage them to continue their lifestyle that is giving us these good outcomes. Okay, and then we reassess a patient every year. So if you have normal blood pressures, it's important to have a yearly check of your blood pressure, so that we don't have you developing hypertension without you knowing. We say the vast majority of our people living with hypertension don't even know that they actually have hypertension. They only get to know when either someone has accidentally or incidentally made a diagnosis or checked them, or when they have a complication. Okay. So when we have elevated blood pressures above 120 to 129, 120 to 129, and systolic that is less than 80, we encourage non-pharmacological therapy. Okay, things like physical activity, things like a DASH diet, things like avoiding high salt intake, things like avoiding smoking, things like a low alcohol intake. We encourage this, and we reassess this patient, this person 3 to 6 months later. However, when we have diagnosed the patient already with stage 1 hypertension, that is 130 to 139, okay, or 80 to 89 millimeters of mercury, we also go ahead and do what? We calculate what we call a clinical cardiovascular risk, okay? Or a 10-year atherosclerotic cardiovascular risk, okay? So we want to do this calculation for our patients. These calculators are online, okay? They're on Google, they're on many apps like UpToDate, okay? They are designed with these apps already. So when you meet a patient with stage 1 hypertension, you want to go ahead and do what? Calculate their atherosclerotic cardiovascular risk. This is their risk of developing a cardiovascular accident, okay? By this, we mean things like embolisms, we mean myocardial infarcts, okay? VTEs. So these are risks of strokes, okay? So this is a 10-year risk, of atherosclerotic cardiovascular disease. So if they fit in that criteria and they're having stage 1 hypertension with a 10-year risk that is less than 10, then we continue with our non-pharmacological therapy for 6 months again. And we said we always reassess after 6 months, okay? If BP targets are greater than, if our BPs are greater than the targets that we expect, then we continue with our non-pharmacological therapy and consider starting our drugs, okay? We consider starting our drugs because our non-pharmacological methods or therapy interventions have done what? Are not succeeding, or they're not sufficient to achieve our BP targets. Now, if our patient has stage 1 hypertension and their 10-year atherosclerotic cardiovascular disease risk is more than 10%, okay, then you're going to find that we are going to do our non-pharmacological therapy, and then also we're going to initiate drugs. Okay, we're going to initiate drugs for this patient. Then we have to assess this patient every month. Okay, we have to assess this patient every month. Okay, then if the patient has stage 2 hypertension, we already know the ranges. I will not repeat them, but you can see them on your screen. We are going to continue with non-pharmacological therapy, and also our medication will continue. Then we will reassess the patient every month again. Okay. So one thing I want us to take note of is the fact that across the board, non-pharmacological therapy is taking precedence. It applies everywhere, even to people with normal BPs. Non-pharmacological modalities of treatment or lifestyle modification is the cornerstone of hypertension management. So everyone, including people with normal BPs, have to embrace lifestyle modifications. That means diet, that means physical activity, that means avoiding a lot of alcohol intake, avoiding a lot of salt intake. All these are very important across the board, okay? Now, what changes is whether someone needs pharmacotherapy management or not, but the rest apply everywhere, as you can see, okay? So again, like I mentioned before, lifestyle modification is the cornerstone of prevention and treatment of hypertension. That's why this slide is there with all this detail, okay? So weight loss is very key in controlling hypertension, in the sense that you're going to lose almost 5 millimeters of mercury, okay, of your blood pressure. You're seeing that? So you imagine losing 5 millimeters of mercury just from weight loss. That's a huge reduction, without buying a pill, without taking a pill. So I recommend that we consult physiotherapists to tell us or to show us ways in which we can lose weight through physical activity, or to consult nutritionists on ways in which we can lose weight through diet, because it is very important. So a healthy diet will drop your BP by 11 millimeters of mercury. That's a very huge, a very huge reduction. You get that? So even if you are normotensive, you can see how much loss you get. 2 to 3 millimeters of mercury for weight loss and 3 for healthy diet. So we are seeing that lifestyle modification alone seems to help a lot. Okay, even more than some drugs would do. So reduced intake of dietary salt. We are supposed to have less than 1.5 grams of salt per day. If we want to maintain blood pressures that are within normal range. So you can see we lose, 5 to 6 millimeters of mercury. If we maintain that diet we are talking about. Okay. Uh, potassium intake. So now we're supposed to reduce sodium intake, but enhance potassium intake. Potassium has a role in causing vasodilation. Okay, in causing vasodilation. So we're going to have reduction in blood pressures as well if we enhance our intake of potassium. Again, I would like to ask us to consult a nutritionist. What kind of diet, has a lot of has enough potassium for us? Things like matoke, things like juices that have potassium. So I will, because I'm focusing today on pharmacotherapy. I will not dwell a lot on explaining the detail of what kind of foods have these things. And the other is physical activity. We have seen that we have aerobic, we have dynamic resistance activities, we have isometric resistance activities. All these reduce blood pressure. As you can see, they reduce blood pressures, on within the ranges you're seeing on the effect on systolic blood pressure, and also moderation of alcohol intake. You can see that for men, 2 drinks daily, for women, less than 1 drink daily would be good. We have a reduction of almost 4 millimeters of mercury every day. Okay, so generally, what I'm trying to lifestyle modification is very important in that. Imagine you did physical activities and then you added on weight loss and then had a good diet and then reduced your salt intake. How much reduction in BP would you have if you are consistent? Okay, one thing you have to note is these things require consistency. They are not things you achieve after 1 week of trying to do these things. You have to be very consistent. Again, I would say the professional people in these areas are physiotherapists and nutritionists. So I would like us to make use of them when it comes to these areas of this area of non-pharmacological methods of managing hypertension. So me, I would like to go deep now into pharmacological treatment. As a pharmacist, this should be like on your fingertips because you're the drug expert. Okay. So American Heart Association and American College of Cardiology, again from their scientific statement 2020, okay, they gave us some sort of, some guidelines on how to go about hypertensive patients. The first thing we need to do is have a discussion with the patient. As a clinician, there should be a discussion between you as a health worker and the patient, because both of you are stakeholders. It is the patient's life. Okay, so the patient has to agree to the goals you want to achieve for them. Now, sometimes we come up with our own goals and then we impose them onto the patient. Trust me, they will not take your goals seriously. After 1 week, they will stop. They will go back to their alcohol. They will go back to their 5 bottles. Okay. After 1 week, you're telling them to do sit-ups every day. After 2 days, they will stop doing the sit-ups and then they will tell you how they're tired, how they have muscle cramps. So you need to discuss your goals with the patient or come to an agreement concerning these goals. So first line, uh, therapeutic classes for managing calcium channel blocks. Okay, calcium channel blockers are very important. And then S inhibitors and ARBs are very key. And then thiazides or thiazide-like diuretics. Okay, we have thiazide and thiazide-like diuretics. You guys are now intern pharmacists, so I expect you to know examples of each of these drugs. Every class you should be able to list like 5 examples, so that they say a good pharmacist is one that knows pharmacology. So you can see that. Okay, thank you very much. Those guys who were in the chat. Thank you very much. Keep them coming. So we are seeing that monthly visits, okay, are very important in our management of hypertension until our goals are achieved. We need to keep monitoring these patients, every month, so that we can see we're achieving our targets or not. Two readings, okay, in the morning and evening, 3 times a week is very, over 3 days in a week is very important for us to keep track of if we are actually achieving our targets or not. It's important to have a record of our BP readings for purposes of tracking progress of the patient's outcomes. So the other thing is fixed drug combinations are very important because they reduce pill burden. Okay, they reduce pill burden. So when you find some medication, instead of prescribing 2-3 pills, if you can find a combined pill with 3 drugs or 2 drugs in one, it can be very helpful for your patient. If BP is not, if BP goal is, if you've not achieved your BP goal, then it's good to assess for things like adherence. Okay, so usually we don't take seriously the reason why the patient is not adhering. We will blame the patient all the time, but sometimes you've given them medication that are causing a lot of side effects. Okay, and they are struggling to take your medication. They're having a headache from nifedipine. They're having a dry cough that they can't allow them to sleep because they are on lisinopril or captopril. You're getting my point? So you find that your patient goes off your medication. So it's important to pay attention to this if you're not achieving your goals. Dose titration is important. One thing we need to know is when we initiate drugs, strive to achieve the maximum dose that has been observed in clinical trials to cause reduction in blood pressure or to achieve outcomes. Okay, we don't initiate drugs and stop at that dose we initiated. We initiate drugs and strive to achieve the dose that was observed in clinical trials to be beneficial. We have to know that. Now, looking at the second line therapy, classes for therapy, we can see beta blockers come in, and they're using special, special indications like ischemic heart disease, heart failure, even things like hyperthyroidism. We can benefit from some beta blockers. We can as well also use mineralocorticoid receptor antagonists, things like spironolactone and eplerenone are very important in that case. We can as well use alpha-1 antagonists like prazosin, okay? All these are important, but depending on the indication. Direct vasodilators like minoxidil, we have some that are actually non-selective like avedilol, these are also very beneficial in heart failure, in hypertension management with certain indications. I already mentioned heart failure somewhere. Yes, it was because of the role of carvedilol in heart failure. So we have potassium sparing diuretics. We have loop diuretics. We have central alpha 2 agonists like methyl dopa. All these are important in hypertension management, but they act as add-ons. Okay, we have our primary drugs, the calcium channel blockers, the ACE inhibitors, the ARBs, the thiazides, or thiazide-like diuretics. Okay, so what I've been going through has been the American Heart Association, what they're telling us. So usually we forget and discuss a lot about what the Americans are doing or what the Europeans are doing, and then we don't know our own guidelines. Okay, so our own guidelines, what do they say about hypertension? Now going back to our guideline, we noticed that our guideline actually still uses this classification where we are having pre-hypertension. For us in the UCG, we have a new UCG that came out last year, and we are having this category pre-hypertension there. Okay, so our experts in Uganda have maintained it that way, and for us in Uganda, stage 1 is from 140 to 159 systolic, and then diastolic starts from 90 to 99. Hypertension, stage 2 starts from 160 and above systolic, and then diastolic of 100 and above. Okay, so unlike the American one, where they made that revision for us, we have maintained that. Okay. Looking at how the management of hypertension has been outlined in our guideline, still step 1, very important, is lifestyle adjustments. Okay, very important is lifestyle adjustments. And you can see I've already talked about all these, so I will not go through them again. I will not go through those again because we already know them very well. Step 2, that is very important, is emphasizing still lifestyle. And then at this stage, we start to initiate what? Amlodipine, 5 milligrams once daily. Okay? We start to, these are patients who have stage 1 hypertension. When we fail on lifestyle and we do our reassessment after a month, we initiate amlodipine, 5 milligrams once daily. Okay, then again, we reassess after a month. Okay, if we are failing to achieve our outcomes, we do what? We will treat this patient as a what? A stage 2. We will treat them using the stage 2 modality. Okay, so hypertension stage 2, according to the UCG, we start with amlodipine 5 milligrams, then we add on. Once a patient is in stage 2, we use 2 drugs. We will either use a calcium channel blocker combined with an ARB, or we will use a calcium channel blocker combined with an AC inhibitor. Okay, so we have to take note of the doses, and like I said, we have to optimize doses. We don't want to stagnate and continue using doses that are not optimized. If the patient isn't achieving outcomes with 5 milligrams, we have to do what? Upgrade it all the way up to 10, the maximum tolerable dose for this patient. So instead of using ARBs, sometimes they can use ACE inhibitors. Okay, so this can be used interchangeably. However, we cannot use the two at the same time because we will have a very high risk of kidney injury and also a high risk of electrolyte imbalances, particularly hyperkalemia. Okay, so looking at stage 4, if our patient's blood pressures are above 140 systolic and above 90 millimeters of mercury after 1 month, then we will give our patient amlodipine 10 milligrams. Then we will add on an ARB, okay? 50 milligrams of losartan or valsartan or telmisartan, as you can see, once daily. So like I said, in stage 2, we are using 2 drugs, not 1 drug anymore. Then we optimize the doses for both of them. We don't stagnate. For stage 5, for step 5, under management of hypertension in stage 2, we are going to still use amlodipine. So we are seeing that our blood pressures are above 140 diastolic and above 90 diastolic after another month of treatment, and we are not achieving our targets. So we'll give this patient amlodipine 10 milligrams. We will also give them an ARB, as you can see. Then we shall add on a diuretic, a thiazide. Okay, so our guideline recommends bendroflumethiazide or hydrochlorothiazide. Okay, however, we have to know that we have thiazide-like diuretics that have cardiovascular benefits. Okay, our guidelines are usually made based on availability, based on cost, based on cost-effective, that whole calculation, pharmacoeconomics. However, we could have drugs that actually have benefits. So thiazide-like diuretics have a cardiovascular benefit that thiazide diuretic over thiazide diuretics. Okay, so our guideline says bendro and hydrochlorothiazide. However, you could as well use thiazide-like diuretics. Drugs like indapamide, clothalidone, these are drugs that are thiazide-like diuretics. And like I said, they have a cardiovascular benefit in the sense that they will reduce the risk of cardiovascular accidents. Okay, so I would recommend those who can afford to actually use those. Now, when I was looking at this guideline, I noticed step 5 and step 6 look very much similar. Okay, they look very much similar. I couldn't tell the difference. In case there's anyone that participated in the designing this guideline, the Uganda clinical guideline, they could have maybe enlightened us on the difference between step 5 and step 6. But I noticed it's pretty much the same, but it doesn't change the gist of what we are discussing. Okay, it doesn't change the gist. So here, BP is about of treatment, and then if you're not achieving our goals, we are still using 3 drugs: a CCB, an ARB, or an ACE inhibitor, together with a thiazide diuretic, what I said, like diuretic, like I already mentioned. Okay, these are now 3 drugs. Then the final step is step 7. These are patients who have BPs above 140 and the systolic and above 90 diastolic. And these patients have not responded with all the interventions we have been doing. So sometimes they actually have another undiagnosed cause for their hypertension. Okay. So according to the Uganda clinical guideline, they say we refer them to a higher facility. Okay. So if you're at a level of a hospital, you want to send them to a referral, regional referral hospital. If you want to send them to a national referral, or even to, to Heart Institute where we are, we would gladly, help find a way of helping this patient. So, in summary, patients with diabetes, coronary heart disease, stroke, or chronic kidney disease, according to the UCG, are considered high cardiovascular risk patients. Okay, these are patients who have a high cardiovascular risk. In other words, they are at high risk of having cardiovascular accidents. Okay, they are at high risk of of having a cardiovascular admission. Okay, so these are patients. So we are saying that the target BP is less than 1/3, less than 80 in people with a high cardiovascular risk. So if a patient has diabetes already, and then they also have hypertension, our target BP should be less than 130, less than 80. If they have a chronic kidney disease, if they have an ischemic heart disease, if they have a stroke, if they have a CKD, these are patients who have a high cardiovascular risk. So their target is less than 130, less than 80. Now, statin therapy is also very useful for these kinds of patients, particularly the ones that have had a history of heart attack or an ischemic stroke. Okay, so statin therapy, we always do atorvastatin 20 to 40 milligrams or simvastatin 20 to 40 milligrams once daily. Then we add on antiplatelet therapy, particularly aspirin. Okay, this is what our guideline says in Uganda. Once a patient has a high cardiovascular risk, we add on a statin therapy. We also add on antiplatelet therapy. Then we consider statin therapy, like I've already mentioned, in patients who are having a high cardiovascular risk. Okay, so we are seeing that yes, we do our management with antihypertensives, but we add on what? We add on statin therapy. We also add on what? Antiplatelet therapy. Okay, where they have a high cardiovascular risk. Okay, now the other thing is we also initiate beta blockers in patients who have had heart attacks within the past 3 years. So beta blockers that the guideline in Uganda recommends is atenolol, bisoprolol, and nebivolol. Okay, these are given once daily. Okay, these are given once daily. And then we also have a combination of we can do a combination of an S inhibitor or ARB together with a calcium channel blocker or a diuretic when our patient has chronic kidney disease. Okay, so patients who have chronic kidney disease will benefit from a beta block, sorry, an S inhibitor or ARB or calcium channel blocker, or they will also benefit from a diuretic. So the calcium channel blockers, so these patients tend to have things like proteinuria. Chronic kidney disease patients might have things like proteinuria. So you will find that ACE inhibitors are beneficial in reducing, the extent of proteinuria, and even ARBs are also beneficial. Very common in chronic kidney disease. So these are benefits that ACE inhibitors and ARBs have among these patients with chronic kidney disease. So calcium channel blockers are safe for the CKD patients. However, we also have categories that do what? Categories that are beneficial in preventing proteinuria, particularly the non-dihydropyridines, okay? Like verapamil, diltiazem, they are very beneficial in reducing the extent of proteinuria in this patient. So you find that these are drugs that are beneficial in patients who have chronic kidney disease. Loop diuretics are very beneficial in reducing fluid overload in patients who have chronic kidney disease. Okay, they're the most potent diuretics that we have, so they help reduce proteinuria. Then also, the other thing is we find that sometimes we add on thiazide-like diuretics, like I had mentioned before, things like metolazone, indapamide, or clothalidone, amongst these patients, so that we can reduce the extent of kidney. Sorry, we can benefit from the cardiovascular benefits that these drugs have. Okay. The other, so we find that these patients for hypertension, that is secondary to thyroid disease, we normally benefit from beta blockers. Okay, like I had mentioned before, beta blockers are very beneficial in certain categories of patients, including things like pheochromocytoma, hyperthyroidism. They benefit a lot from management when you use beta blockers like propranolol. These are non-selective beta blockers. Okay, we give a dose of 40 milligrams twice daily. So the guideline warns us that using ACE inhibitors and ARBs is not safe in pregnant mothers because of the risk of fetal nephrotoxicity. And same applies to diuretics, particularly loop diuretics, are not very safe in pregnant mothers, still because of the same risk. So we tend to use methyl dopa and calcium channel blockers in expecting mothers to manage the hypertension. And then also we try to avoid ACE inhibitors and ARBs because of the increased risk of electrolyte imbalances, like I mentioned already, and also because of the risk of kidney injury that can be caused by combining these drugs. So our guideline lists certain compelling indications. Okay, if a patient has hypertension together with heart failure, there are some drugs that we are going to use, and we have to know this. This chart is very important. This chart can someone can set a question from this chart. So heart failure, hypertension together with heart failure, what is our choice of antihypertensives? Okay, as you can see that our choice of antihypertensives is now we'll use a diuretic. Okay, you get the point. A diuretic together with a beta blocker in heart failure, and then together with an ACE inhibitor, and then usually we can add on mineralocorticoid receptor antagonist. Okay, so someone who has hypertension together with heart failure, they will benefit from those. Okay, so remember, we avoid treating disease. We avoid giving patients drugs treating diseases independently. You want to handle the patient as a whole. So when the patient comes in, you want to ask yourself, what other comorbidities do they have, and which drugs can I give them that can benefit them? They can benefit all these comorbidities instead of treating each condition independently. Okay. So when a patient has a myocardial infarct or they have a post-myocardial infarction, you will benefit from beta blockers. Beta blockers do what? Reduce oxygen demand on the heart. Okay, reducing the extent of damage caused by the occlusion of the coronary artery. Okay, ACE inhibitors also reduce afterload. So this also reduces oxygen demand on the heart. So seeing that the choice changes. Angina, we benefit from beta blockers for the same reason. They reduce oxygen demand on the heart. Okay. Then calcium channel blockers in angina, we go for particularly non-dihydropyridines. Okay, verapamil and diltiazem, these are beneficial in reducing heart rate and therefore reducing oxygen demand. So in patients who are diabetic, we benefit from ACE inhibitors and ARBs because they do what? Remember, we talked about the benefit of reducing proteinuria. Okay, diabetic patients have a complication of what we call proteinuria. And proteinuria causes what? Diabetic nephropathy if left untreated. So we'll give them ACE inhibitors. Okay, shooting two birds with one stone. Calcium channel blockers are also safe for diabetic patients. Okay, so patients who have a kidney disease, of course we give them diuretics to reduce fluid overload. Okay, at any stage of kidney disease, they will benefit from diuretics, loop diuretics particularly, not any. Okay. Beta blockers are also safe in patients with a kidney disease, and then calcium channel blockers. Give them a diuretic. We can also give them calcium channel blockers. These are safe for these patients. Okay. So when we are discussing about beta blockers, according to our guideline, the UCG, when you say beta blockers, we are referring to carvedilol or bisoprolol in the management of heart failure or angina or myocardial infarction. So we are referring to those two according to our guideline. So like I mentioned before, guidelines tend to recommend what is readily available for the citizens of that country. So that is partly why you might see some of the limitations in our guideline, but which is okay, they help us. So what are the monitoring parameters? This is a very important part for a pharmacist. Okay, this is a part that this is where the gap is. Okay, when it comes to management of our patients, we give them drugs, then we let them go away. Okay, this is where the gap is in many healthcare facilities. You find that the patient is not being monitored. And who is supposed to do that? The clinical pharmacist, okay? Because you're the drug expert and you're the one who understands these drugs very well that are being given to this patient, okay? Meanwhile, the cardiologist, so the physician is very much concerned with making a diagnosis. For you, your concern is safety, adherence, indication, and effectiveness of your treatment. And this is where the gap is. You find patients dying from what? Electrolyte imbalances. Patients are dying because of drug overdose. Patients are dying because of kidney injury caused by what? A drug. Why? Because there was no one to check for that. Okay? There was nobody to check for that. So I want to interest us with monitoring parameters for spironolactone that belongs to aldosterone antagonist, that class. We monitor for blood pressures definitely, because remember we are dealing with the antihypertensives. We have to check for BUN, creatinine. We have to check for electrolytes like potassium. They must be within range. Okay. We know that we don't initiate spironolactone if a patient has potassium of 4.5 and above. Okay. We know that when a patient has a creatinine EGFR of 45 and above, we are very cautious, to initiate our spironolactone. Okay. ACE inhibitors as well elevate potassium of our patients. So the same criteria falls for them as well. And then also we say the EGFR, some guidelines will say EGFR less than 30, we don't initiate ACE inhibitors and ARBs. Okay. However, if the patient has already been on them, we can continue with them, but we do not newly initiate them when we discover our patient is newly diagnosed and they have what? They have EGFR less than 30. Same applies to ARBs. Calcium channel blockers are much safer. They just monitor for blood pressure and also monitor for the heart rate of the patient. Diuretics, we also check for blood pressure. We also check for BUN creatinine ratio, because they can also cause can also cause kidney injury. We know that loop diuretics have that potential. And then we also know that the benefit of thiazide has a ceiling somewhere. Okay, below a certain EGFR, we don't use thiazide because the benefit is not there. Okay, it only gives the patient side effects. Okay, thiazide also tend to cause what? Increased levels of uric acid, therefore precipitating gout. So you want to observe your patient for all this. Okay. And then beta blockers, of course, still we monitor blood pressure, and we also check for the heart rate of this patient. Okay, so that ends our usage, where what our usage tells us about management of hypertension. Okay, now I want to just look at a few things, and then I will close my discussion. There's something called resistant hypertension. So the European Society of Hypertension tells us that this is what we call this is hypertension that has been resistant to treatment, like appropriate lifestyle modification. Okay, treatment has been optimized up to tolerable doses, or using 3 drugs or more. Okay, a thiazide or thiazide-like diuretic together with an ACE inhibitor or an ARB, or together with an ACCB, and the patient is still having what? Elevated blood pressure. Okay, so we have failed to achieve less than 140, less than 90. in this patient. So we call that, according to this guideline, we call it resistant hypertension. So remember, we have to make sure there is evidence that the patient was adherent to their medication. Okay, before we start concluding or rushing into conclusion and saying the patient has resistant hypertension, we have to make sure the patient was adherent to their antihypertensive treatment. Okay, then we also have to exclude secondary causes of hypertension. Okay, that means we have to make use of our cardiologist very much. He should be able to rule out any other secondary cause of hypertension in this patient for us to conclusively say this patient has resistant hypertension. Okay, so in patient with resistant hypertension, we normally initiate a fourth line of treatment. Okay, on top of a CCB, an ARB or ACE inhibitor, and then a loop diuretic, we can initiate on mineralocorticoid receptor antagonist. Okay, on top of a CCB, ARB, and a thiazide-like diuretic, sorry, not loop, thiazide-like diuretic, we initiate on spironolactone, which is MRA. And this evidence was seen in the Pathway 2 trial. If you'd like to see the details of that trial, you could kind of look it up. Then also, we recommend a dose of spironolactone of 25 to 50 milligrams every day. Okay, it's total daily dose. Okay, and like I mentioned before, eGFR less than 45, we are cautious. Why? Because of the risk of hyperkalemia in these patients. And then plasma concentration of potassium above 4.5, we are also very cautious because we don't want to have their hyperkalemia going out of range. They have other, hypertension. We don't want to give them a hyper. Okay. Then we have another concept called isolated systolic hypertension. And these are patients who have systolic blood pressure above 140, but the diastolic is less than 90. Okay. So in these patients, we use calcium channel blockers and thiazide-like diuretics. CCBs like amlodipine, nifedipine, they work, okay? Or even non-dihydropyridines like diltiazem, verapamil, they work. Together with thiazide-like diuretics like what? Like metolazone, indapamide, clothalidone, they also work for these patients. However, ACE inhibitors and ARBs have showed less efficacy in this category of patients. ACE inhibitors and ARBs should be used as first line when the patient has compelling indications like what? From our chart, remember the table I told you that can be set. That table tells you that in a patient who has heart failure, we benefit from ARBs and ACE inhibitors. Even patients who have coronary artery diseases, okay, ischemic heart disease, they also benefit from ACE inhibitors and ARBs because they reduce afterload. Okay. Then also, patients who have CKD can also benefit from this because remember they do what? They prevent proteinuria. Diabetic patients also benefit from what? ARBs and ACE inhibitors because they also do what? Because they reduce proteinuria as well. Okay. So patients who have, what about the ones who have isolated diastolic hypertension? So the previous one was isolated systolic hypertension, and we have seen its management. Now, isolated diastolic hypertension usually manifests with systolic blood pressure less than 140, but diastolic above what? Above 90. Okay, so there is no evidence so far on how to go about this hypertension. Therefore, the management depends on what? The management is very much like the management of the general, hypertension, the usual hypertension we manage, which we have discussed at length. Okay. Then we have something else called hypertensive emergency. So hypertensive emergency and urgency, these are two terms that are confused. Hypertensive urgency is when you're having BPs above 180 by 120. Okay. Then emergency is different from urgency in the sense that we are having end organ damage. Okay. The two are similar in terms of BP readings. Okay. Above 180, systolic, above 120, diastolic. However, the difference is in the fact that for an emergency to be for us to say it is an emergency, there has to be end organ damage. Okay. So many times you find patients walking, they're okay, they even they've come for your medical camp and they're having BPs of above 200 by That's a patient who has hypertensive emergency. Those ones need admission. Why? Because there's end organ damage. End organ damage meaning things like an AKI, acute kidney injury. Okay, the kidney has been, injured, or we have actually an hemorrhagic stroke. Okay, the patient has a stroke because of their hypertension. So these are the things we're talking about: end organ damage, and usually what we want to do is to achieve a BP of less than 160, less than 105. Okay, so patients who have urgency, I'll just mention this. Those patients just need to be initiated into into treatment of hypertension. So we consider them as stage 2 hypertension patients. That means we will not use one drug. We will not use two drugs. We saw in our treatment of stage 2 hypertension that we start with two drugs and then we optimize them and then we later on initiate even a diuretic. Okay, so we handle them as stage 2 hypertension patients. Okay. Um, So hypertensive emergency usually manifests clinically as severe hypertension associated with conditions that need intensified BP management, like what? A stroke. The patient will come and they already have a stroke, hemorrhagic stroke or ischemic stroke, together with their high BPs. Okay. And then they have an aortic aneurysm. Okay. Or they can have acute heart failure. Okay. This is the patients who are decompensating already, acute decompensated heart failure, secondary to hypertension or hypertensive emergency. Patients who have acute coronary syndrome, okay, kidney failure or kidney injury. This is how they will present to you when they have an emergency. Then patients, they can also come with having what we call pheochromocytoma. Okay, these are patients who are literally having a spike of their catecholamine, catecholamine hormones. They are, all over the place. They got spike. So you find that there is sort of a steroid, a state of a state of BPs being elevated. Then you're having blood vessels contracted, you know, vasoconstriction. So you find this patient will have high BPs. This can be caused by substance abuse. Very common among cocaine abusers. Okay, uh, so you will find these patients showing up like that. Okay, so these are patients who need quick attention. These are emergencies. So to conclude my discussion, there are drugs we use in managing hypertensive emergency. There are drugs we use in managing hypertensive emergency. So we have drugs like esmolol in our setting. The dose is what you're seeing. Onset of action, time for onset of action, 1 minute, the drug is acting already. So drugs that are used in hypertensive emergency, what we need to note is they have a quick onset of action. You can see minutes, not hours. Okay, the quicker the better. Okay, and then they tend to have a short half-life or short duration of action. Why? Because in a patient who has an emergency, we need to be able to modify doses. Okay, if the one we have given is not working, we should be able to give another dose. Okay, if the one we have given is too high, we should be able to do what? If you have a window where the drug wears out quickly. Otherwise, if you give them a long-acting drug like losartan, then you're going to end up doing what? Oh, amlodipine. You're going to end up doing what? You end up dying with your patient. Okay. So drugs that are used for hypertensive emergencies have a quick onset of action and also have a very short half-life or a very short duration of action. So the doses are what you're seeing there. Your role as a pharmacist is to find out which one is available in our setting. Okay, when a patient has been dropped into your facility, which drug can we get for them as fast as possible? Okay, so these are their contraindications. Please make sure you go through those, and also their adverse drug reactions, as you can see. Okay, we also have these on the next this slide I'm displaying. You can see that the drugs are there. You can still notice that their onset of action is quite quick, and also their duration of action tends to be quite short as well. Okay. One thing I have to stress very much is in our facilities, particularly lower facilities, we have a habit of giving our patients sublingual nifedipine. So I want to always remind us that it is dangerous to do that because you crash BPs suddenly. You suddenly crash BPs, and then when you suddenly crash a patient's BPs, what happens? You're going to have hypoperfusion of what? Of organs like the brain, the kidneys. So the organs shut down because of what? Reduced blood supply. Okay. Remember, they came in with a very high BP. Now you've just crushed them suddenly. So what happens is these patients are at high risk of what? Getting ischemic stroke, getting acute coronary or myocardial infarcts, or even acute liver injury. Okay. So so we find that we will have a problem or a problem with this patient. So I would like to come to I've come to the end of my discussion, and these are some of the references that I used when I was preparing the work, and you can as well look out for them. I've left out a lot of things, as you will notice. If we can discuss hypertension for a week and we will not finish. I've left out management of hypertension in special populations, pregnant mothers, in pediatrics. I've left out all that. I've also left out, I am aware that we have pharmacognosy interventions, okay, in our setting. These are very important things. I pray that we need to start having we have someone from pharmacognosy in the subsequent Zoom sessions discussing management of these things using pharmacognosy intervention. And then also the other thing is I've left out some of the things that um, I've not looked at some of the things that what you're going to be said. This is just a refresher course. I know you already started these things, so there's nothing new that you're being told here, but it's just to remind you. So thank you very much. Let me invite questions at this point.
Thank you so much, Doctor, for that wonderful presentation. Head into the Q&A session. The rule will be you raise up your hand in the chat, and the presenter asks you. So we shall raise our hands, the presenter will pick us, and then we shall question. Yeah, I think it is very important to mute. I don't know. Patrick, yeah. Okay.
Jasper, there are some questions in the chat. I would suggest that we start with those as other people prepare their own.
Okay, it's okay. We can start with those. Yeah, I think we shall start with those. Then we'll the raising of the hands will follow later on. Yeah, so mine would be on nitroprusside and its cyanide toxicity. I don't know, because I read somewhere about how it needs very close monitoring, and I was wondering whether it's actually worth it in relation to all the available alternatives. And also he didn't talk about hydralazine as for hypertensive emergency. Then I would also request him maybe to elaborate a little bit more on the dash that. Probably we'll do that after we handle the questions in the chat. So, Doctor, are you on? Dr. Silas?
Yeah, I'm on. I don't know if I can answer those.
Hello.
Okay, let me start with nitroprusside. PSU Secretary, Dr. Stephen Dototi. I'm very glad that you logged in. And also, I would like to acknowledge anyone else that could have joined in, apart from the interns. Thank you very much for being a part of this. I'm honored to know that you joined in to listen to what we were discussing. So I also see that you have informed us that hibiscus exhibits ACE inhibitor properties. So that is something for us maybe to note. Hibiscus has ACE inhibitor activity, like Dr. Lot is saying. Therefore, we should be careful when combining ACE inhibitors and hibiscus. And then also he mentions that Wabugia ugandensis can cause hypertension. I'm sorry, hypotension. So so these are things we have to note. Yeah. Thank you very much for your input, Dr. Lutot Stephen. Going to the question you asked about nitroprusside, hydralazine, nitroprusside, and then nitroglycerin, all these drugs, the betalol, they've been used for managing this hypertensive emergency. So all of them definitely have some side effects here and there. Okay. However, we have to monitor the patient for these side effects of adverse drug reactions. Okay. The safety of some drugs is better than others. Safety profile of some drugs is better than others. That one is what we need to know. So as a pharmacist, you ask yourself, what drugs can I stock in this facility? Okay, that have a good safety profile. And then in case we don't have this, what can we resort to? You're getting this. So it's a thing of weighing risk and benefit. Okay, so it's true that nitroprusside might cause some issues here and there, but it doesn't stop us from using the drug if that's what we have available. Okay. The other thing is hydralazine and its friends. We will tend to cause things like I didn't put it. It's not there in the guideline, but I know we have it in our facilities. These drugs tend to cause hydralazine is a direct vasodilator, and the problem with direct vasodilators is what we call rebound hypertension, and they also cause tachycardias. You're getting it. So you give a patient the drug now, and then in a few minutes, the body responds, a compensatory mechanism to try and maintain the BP. So you've increased the diameter of the lumen vasodilation using your hydralazine, but now you're having a high heart rate. So what do? You're supposed to give this patient a beta blocker alongside what? Alongside the hydralazine. So you see, it's a bit inconveniencing. You're giving the patient one drug, now you give them a second drug to handle the what? The side effect. So it works, yes, but that's the problem with it. The rebound hypertension, the tachycardias that will come along with it. So we try to stay away from it. You only use it when you really have nothing to do. Okay, so you want to stay away from it and go with these other recommended ones. Yeah. I don't know if I have if I've tackled so far.
I think my questions are answered. I think now we should try to tackle those from the chats and then a few hands, and we call it a day. I don't know whether I can access them. My chats have refreshed. I can't see any. Dr. Silas, I don't know whether I can read a few questions in the chats because mine have refreshed and I can't see any.
So yeah, let me quickly we take the one that is higher. If the systolic is out of range and it is in stage 2, but the diastolic is normal, we consider the staging where the systolic will put us. If the diastolic is out of range and the systolic is normal, we consider the diastolic. That's how we handle it. Amlodipine puts patients at risk of swelling ankle. Yeah, that is very true. All drugs have side effects, and amlodipine causes that edema of the lower limbs. I have read American literature suggesting that African Americans, of which Africans are part of, a racial group suggests that we Africans are more prone to getting hypertension. That is true. But if we are to consider their source of literature, it's from a narrow genetic sample. That's also very true. What I mean is Africa is known to be the most genetically diverse. That is very true. And that means that we need to do a lot of studies as Africans. We need to stop relying a lot on literature from the West. That is the challenge, relying on other people's literature. So my responsibility as a clinical pharmacist in Uganda is to enrich our guidelines. That is why we need more and more clinical pharmacists in this country. America has a lot of clinical pharmacists who are very busy working. In Uganda, we have less than 30 or less than 20. So we need to have more of them trained. I hope PSU is listening to this. Uh, someone mentioned step 6 has higher doses of ARBs compared to step 5. Thank you for that observation. Thank you for following. That means someone was able to notice something I didn't see. Kindly classify why stage 4 doesn't have thiazide diuretic, yet the patient is on amlodipine in stage 5 and stage 6. No, I want to remind us that these are not stages. These were steps. When you say stages, now it changes the meaning. These are steps. Clarify why outside step 4 doesn't have thiazide diuretic, yet the patient is on amlodipine. So that diuretic added on has antihypertensive properties. So a patient who is in step 4 doesn't qualify for that additional antihypertensive effect from the thiazide diuretic. Okay, a patient who is in step 5, however, has failed on amlodipine alone. So now we have to introduce what? The thiazide that you're seeing. Someone is saying in stage 5 and 6, it is always advisable to use ARBs combined with thiazide diuretics, unless advised. That's true, unless advised otherwise due to pill burden. Yes, it's true that in step 5 and 6, we will tend to use CCBs or combine ARBs, then we'll bring in thiazides as well later on. The idea is when we have, the guideline is very clear for sure. It's very clear. When you monitor the patient, the BPs are not going after 1 month, you keep on optimizing the dose. And when the optimum dose has failed, we introduce a new drug. That's how it is. Okay. Um, the guideline is very clear on that. Monthly lipid profile can guide us on when to start statins. That is true. However, as we can see in the UCG, statin therapy was introduced in patients who are having what? Ischemic heart disease. Patients who are having ischemic heart disease. So, and a history of ischemic stroke. So, it is irrespective of lipid profile. The lipid profile is very important if the patient doesn't have these drugs. The UCG had a definition of, it has a definition of what we call cardiovascular risk. Okay, and it told us heart failure, it told us diabetes. So these patients are patients who benefit from statin therapy, irrespective of lipid profile. Okay, however, we can go ahead and do what? in a patient without these cardiovascular risks, we talked about calculating the 10-year atherosclerotic cardiovascular risk. And we said if it is above 10, then we do what? Then we initiate statin therapy. Okay? And that calculator is there online. Kindly look it up. So that calculator has somewhere where you input lipid cholesterol levels. Okay? The triglyceride levels. So all these that's all these make the point. Someone Boaz is trying to tell us something, that he's right about that. However, there are scenarios where we initiate statin therapy irrespective of lipid profile. Okay, and the guideline is also clear on that. You could just get that guideline and have a look at it. The usage, it mentions them. In patients, if a patient has diabetes and edema, when do you use, or for handle, when do you use, or what then do you use to handle fluid overload, since diuretics aren't used? Okay, if a patient has fluid overload and they also have if a diabetic patient is hypertensive and they have fluid overload, then that means they possibly have a heart failure, or they have a kidney disease, usually maybe a chronic kidney disease, and that's already indication for loop diuretics. You're getting the point. In fact, even in nephrotic syndrome, we use what? Loop diuretics. So a patient cannot have fluid overload when their kidney function is okay, or when their heart function is okay. Okay? They will have fluid overload when one of these has a problem. Okay? Now, the liver can also cause fluid overload when it is damaged. Okay? But liver damage causes fluid overload because it will also cause what? Damage of the kidneys. So we are saying that the liver, the kidneys, and the heart play a very big role in what? In maintaining volume status of a patient. So once you see your patient is diabetic and hypertensive and they have fluid overload, you want to check for their renal function. Most likely the kidneys are what? Are failing. And also, most likely, maybe the heart is also failing. Or the other thing, maybe they have a liver disease that is causing the fluid overload. The other cause, of course, of fluid overload is a complication of liver disease, low albumin. Okay, will also give you that edema. Or the patient who probably is losing protein through urine, giving us low albumin, giving us fluid overload. So you're seeing that it's mainly the liver that overload, and therefore we will need loop diuretics. Long-term use of cardiac aspirin has been associated with anemia in elderly, so routine CBC is important. That is, thank you for that information. Thanks, Dr. Silas. This is Dr. Totti appreciating us for committing time to share with our interns on behalf of PSU. I'm very happy to hear again that Dr. Totti was on board or is on board. This is very encouraging for me as well. Tell our interns about Clinical Pharmacist Association of Uganda. Yes, we do have an association for clinical pharmacists in Uganda, and the president, in my knowledge, is Dr. Joshua Kipto. His secretary is Dr. Isiko John. That is as far as I know. So we, like I said, we are still few. I encourage us to, specialize as pharmacists. I'm not saying we should all do clinical pharmacy, but I'm saying specialize in areas that we all have interest in. That way we shall grow the profession. Okay, let's not just sit on our big farm. Someone is saying kindly share slides. Yes, I will gladly do that. What about hydrolazine in hypertensive emergency? I think I talked about the problem with hydrolazine. How do we use the atherogenic index to help on that? But it's maybe I'm going to read about it. I'm more familiar with the atherosclerotic cardiovascular risk score and also the cardiovascular risk score. So maybe it's homework for me as well. What of sublingual hydrolazine for hypertensive emergency? So we mentioned avoiding sublingual treatment modalities because of the problems it causes with drastically crashing BPs. One thing I forgot to tackle was BP reduction targets in hypertensive emergency. We don't just crash these BPs, they are targets every hour. And I want There are scenarios where we actually where we have to use both, what we call dual antiplatelet therapy. Okay, now that's a discussion for another day. That is under ischemic heart disease and things like that. I do believe I'll be back to dual antiplatelet therapy that we see in ischemic heart disease or acute coronary syndrome. Clopidogrel has a risk of causing GI bleeding. Yeah, we know that these drugs have side effects. Okay, it's only labetalol that is widely used and readily available on the market. That is true. So as a pharmacist in Uganda, interest yourself in knowing what we have on our market so that we don't pick things from the American guideline and start giving our patients. That's why I discussed the UCG and what it says, because I knew that's what we have in our setting. From my experience, patients on labetalol will get their BPs lowered very fast, but patients die. It's still in shadow. So now this is where we need studies. We can do what we call and case series. When we report these cases, we can compile our findings and actually publish them, and so that the world can get to know that this is what we are observing here. There is a gap pharmacists need to fill there. Doctors end up at prescribing nurses administer it without supervision by. Yes, that is very true. I'm always encouraging pharmacists and everyone I work with, please interest yourself with seeing the patient. Don't stop at dispensing your drug. Go to the bedside, see what the patient is taking. Sometimes a file has well-written notes, very well-written prescriptions, but the patient is taking the opposite of what is written there. So your job as a pharmacist is to follow up and make sure that drugs are being safely used by the patient. Don't stop at dispensing. That is all-day practice. This is now a new era. Hydralazine is widely used at maternity ward. Yes, that is true, but that's the problem we have of using hydralazine. We have pointed them out. Yeah, we said that we can use them, but the challenges, of course, are there. Kindly share. Yes, we'll share the slides. Thank you very much for elaborate training. Can we use hydralazine in a patient with hypertensive emergency and history of ischemic heart disease? It is dangerous. Why? Because the heart, which is already sick. Okay, so we want to avoid hydralazine in a patient like that. You want to stay away from it because then you increase the size of the infarct if they have an infarct. For a person age more than 64 but with cardiovascular risk, with high cardiovascular, do you still consider target BP of less than 130, less than 80? Uh, Now here we have to weigh a lot of things. We say that target BP for this category is less than 140. Okay, they are above 64 and they're having high cardiovascular risk. You want to, if the guideline is saying less than 140, but if we can achieve less than 130, it is okay. Okay, actually I would say less than 130 is okay. By saying I think you're confusing two guidelines at once. Okay, I don't know if Jasper was responding to me or responding to that question. Uh, I think Jasper was trying to respond to Genevieve. I think target BP was cutting across all lines. Lines will give us an update of what other people are doing in other countries to compare with what we are doing in Uganda. So that in case you as a pharmacist, you happen to practice in John Hopkins or you happen to practice in Mayo Clinic, you are not outdated. You are aware what the Americans are doing. You are aware what the Swedish are doing in Sweden because you've had access to their guidelines. And also you are aware what we are doing in Uganda. Okay, I think that there was a debate there between Genevieve and that is very important. Pulmonary hypertension, this could be discussed under, can be discussed under heart failure. Again, heart failure, right-sided heart failure giving us pulmonary hypertension. That is a whole new topic, a whole big topic. Okay, so it is not among what I'm going to discuss, But when I reach heart failure, maybe I'll hint a little on that. Okay. The challenge is I don't have a lot of time. I have, I've been given a short, a small, space of time, and I'm trying to make sure I use it well. So if I had a whole year, we would discuss the things at great length. Yeah. Um, I one time faced a hypertensive patient with cardiac failure, kidney disease, and liver injury. They may, yeah, for sure, these are difficult patients to handle. The moment they have multiple organ failures, you know that you as a pharmacist, you're in a dilemma. And now that's a patient who needs your intervention as a pharmacist in terms of dose adjustments, in terms of interactions, in terms of treatment outcomes. This is why we need you on the ward to look at these things, okay? And then also, our friends from analysis who would be very that can actually check for serum levels of some of these drugs. You get, we want to know how much free drug is available in the serum and how whether we are achieving targets with our doses, or if we are overdosing our patient. Because now for us, we empirically give the patient certain drugs. You give them a drug, you don't know how much protein has bound to the drug, you don't know how much free drug is there, and therefore you're having a small dose of a drug causing a very big effect in the patient, then you end up with toxicities, you know? So these are some of the things that we need to collaborate as pharmacists. We need to avoid fighting one another and collaborate, so that we can have better patient outcomes. I one time faced, okay, we have seen that. Doc, can we please say something about how to manage our patient in cases of crash of BP? Yes, these are when you crash a patient's BP, you've thrown the patient into shock, and now that's when now you manage what we call things we call cardiogenic shock. You start managing cardiogenic shock. Now we use inotropes. Okay, that's why you talk about things like dobutamine, talk about things like noradrenaline and adrenaline. That's when you start talking about these things. Okay. Now I'm talking about hypertension today, but in case I'm invited to talk about shock, we shall also talk about shock, the opposite of what hypertension is. And we also have different types of shock and which inotropes do you use for which kind of shock. That's a very big topic. Okay. So we need to be aware of that. Wonderful presentation. How can one become a clinical pharmacist in Uganda? I trained from Barra University of Science and Technology. That is where I did my clinical pharmacy from. Did a BPharm, then I did a Master of Pharmacy in Clinical Pharmacy. That is how I ended up becoming a clinical pharmacist. I encourage other universities and PSU to make sure this program uh, ends up at Makerere, ends up in Mbarara, ends up in Gulu, ends up in Busitama, and everywhere else. So please, we have a lot of work to do. We should not forget that we are growing the profession. Thank you, Doctor, for the informative presentation, prevalence of heart blocks in hypertension and management. Yes, we have a heart blocks in hypertension. So some of these things, like I don't have them off head, but would look them up as well. Thank you much. Okay, I think I have, and I'm very. I don't know if I've left out anything unanswered about the idiosyncratic causes of primary hypertension, progressive reduction in numbers of nephrons will be the cause of hypertension. I'm not very sure of this. This is homework for me also. I'm not very sure of that. Yes. I think I've exhausted all the questions. I don't know. Yeah, I think I've finished
Okay.
all of them. I would like to stop there, and maybe in case.
Thank you, Doctor. Presentation. I also have a belief that you've exhausted them all. I don't see any hands up. I think they were all able to express themselves in the chat. I see Dr. Lutoti updating us about clinical pharmacy being introduced in Makerere. And also informing us about Uganda, and that is the professional body for pharmacists in the country. Dr. Richard, you're welcome.
Okay, so good evening, friends, and I think I want to thank our colleague Dr. Silas for sparing time to share with us, but also in a special way thank Jasper as coordinating your colleagues and all those who have managed to attend. Let's continue to be more active in DCMEs because we need to update our knowledge every now and then, not just for examination purposes, but to be more competent. So we need to look out, and also as you go through the CMEs, these are opportunities to identify mentors, people you can consult and refine your career. I want you to ask yourself a question as an intern. 10, 20 years from now, who are you? What is it that we really need to know about you? What will define you? Use this internship period to do a self-reflection. Have a meeting with yourself and reflect how far you have come, where you've reached, and where you would wish to be in the next 10 to 20 years. And you start walking that journey. Otherwise, thank you so much. I have learned a lot also through the program. Thank you, Doctor, for sharing, and thanks for everyone. PSU, we will continue to support where we can, and we look forward to having more such sessions. Encourage all your colleagues, those who miss by one reason or the other should be able to catch up. Good enough, you are having recordings of the session. Please take time and go through all this. Make also personal notes as you go through and reflect over what is being shared. Thank you so much. Have a nice evening and happy Mother's Day.
Happy Mother's Day to you too, Doctor, and to everyone in the session. The Pharmaceutical Society of Uganda supports us in very many ways, including having the link, the Zoom link that we are using right now. So we appreciate them for that. Yeah, so at this moment, I would like to thank also, importantly, Mr. Martin, the person at PSU is the one who logs in. Is the one you most likely find at Pharmacy House. He logs in even on public holidays to have us to ensure that we have these sessions. And it's not something that is easy. We really appreciate his effort. And yeah, thank you so much, Mr. Martin. Yeah, so at this time, I think I will have to close the meeting, to adjourn the meeting, to adjourn the session, because I know we're just adjourning. We believe we shall have Dr. Silas very soon for another topic. So thank you so much, everyone, in attendance, and we'll meet next time.